Okay, good afternoon, everybody. One thing I wanted to do, just a little housekeeping first, is that Dr. John Walkup will be here next week. He's going to be giving a talk on diagnosing and treating Tourette syndrome. That's going to be Friday, May 4th at Keywood Auditorium, which is actually the next big conference room over. So please attend if you can. It should be a very interesting discussion, and so we look forward to having him here. Today I'm introducing our Grand Round speaker. Today Dr. Imtiaz Rasool will be doing his discussion on mood disorders in children and adolescents. He doesn't have anything to disclose with respect to financial, well, at least not that I know of. Nobody paid him to do this talk. Dr. Rasool graduated from the Zidwan Medical College in Karachi, Pakistan. He spent a couple years doing his internship and PG2 year on the East Coast. He joined us to do his third and fourth years in his residency program, and he's currently one of the co-chief residents. He will be leaving us in July to do a child fellowship in Florida. And while we're sorry to see him go, we're excited for the opportunity that he has there. In addition to his clinical, to his educational experience, he has also worked in a state hospital, in a very high-volume state hospital. So he has a lot of experience working with various kinds of patients. So I look forward to his talk today, and thank you very much.
And I would like to thank you, all of you, coming and attending the presentation today. So my topic of presentation is mood disorders in children and adolescents. First of all, I will talk about epidemiology. So the major depression in women is, if we see the prevalence, it's 25% in women and 5 to 12% in men, and the prevalence in children up till age 12, it's 1 to 2.5%, and it's 8 to 20% in adolescents. And before age 10, it is more in boys as compared to the girls, and the lifetime prevalence of dysthymic disorder, it's 6%, and it's the major high proportion with the childhood onset. 15% of adolescents with the major depression develop ultimately bipolar 1 disorder, and it's a significantly high rate. Bipolar 1 disorder lifetime prevalence is 0.4 to 1.6%, and bipolar 2 disorder prevalence is 0.5%, and cyclothymic disorder lifetime prevalence is 3 to 5%. And there are no any replicated and authenticated data, but according to some studies, the prevalence of bipolar disorder, it's 1% in youth age 14 to 18, and prevalence of severe mood dysregulation, it's 3.3% in youth from age 9 to 19. And if we see that in a bipolar disorder, so depression is often the first symptom of bipolar disorder in children and adolescents, and there is a pretty high rate of switch rate, which is 20 to 49% from major depression to bipolar. And in this slide, I have put like the onset of age in bipolar disorder. in age less than 13 years, it's 28%, and then in between 13 to 18%, it's 13 to 18, it's 37, and it's pretty much close to the same after age 18. And this is the data from the retrospective study with the 983 patients from systematic treatment enhancement program for bipolar disorder. And if we talk about comorbidity, and so the depression in children overall, there is a 66% comorbidity, and most of the comorbidities in anxiety disorders. And for bipolar disorder, this comorbidity is with ADHD, and it's 60 to 90%. And in this slide, there is a comorbid disorders comparison between children and adolescents for any anxiety disorder, panic disorder, separation anxiety, attention deficit, hyperactivity disorder, conduct disorder, and substance abuse dependence. And so these are the rates, and these are all statistically significant in all these disorders if we compare the children with the adolescents. In this slide, I have put the genetic aspect. So the rate of depression in first degree relatives, it's pretty high rate, like 57%. In children, adolescents, it's 25%. And if the mother has depression, the child has 30% lifetime risk of depression, and it is 15-fold increase as compared to the controls. And in preschoolers with depression, there is a twice the family risk of bipolar disorder than the healthy control ones. And if the parents have bipolar disorder, the children have 4 times population risk for any mood disorder, and 50% have a bipolar spectrum disorder. And if the both parents, they have bipolar disorder, their offspring have increased rate of irritability, depression, rejection, sensitivity, even in the absence of diagnosable disorder. Like even those kids are not diagnosed with the bipolar disorder, but still that population has these elements of irritability, depression, rejection, sensitivity. And in preschool children of bipolar parents, there is a greater lifetime prevalence of any axis 1 disorder, ADHD, disruptive disorders, and mood disorders. And there are no mood disorder in comparison subjects. Even if no mood diagnosis, as I had mentioned before, offspring has significantly more number and severity of depressive or manic symptoms. In regarding the genetics, I mean, there is no definite site identified for either disorder, but a variety of loci have been pursued, which are brain-derived neurotrophic factor, glutamate, decarboxylase 1, and dopamine transporter. And regarding the imaging studies in depression, there are several studies which have found smaller prefrontal volumes particularly among depressed children and adolescents with a family history of mood disorders. At least 2 of 3 studies found smaller left hippocampal volumes and larger left amygdala volumes in pediatric patient population with depression. And one study found larger pituitary volumes in depressed adolescents. And some these imaging studies, for example, SPECT scan showed reduced perfusion in left anterolateral and left temporal cortical areas in depressed adolescents. And the interesting thing is that that has been resolved with the treatment in these patients. And there are conflicting results on magnet resonance spectroscopic studies, but overall implicate the amygdala and dorsolateral prefrontal cortex. And some MRI studies in bipolar adult patient population, they have shown deep white matter hyperintensities, and MRI in bipolar children, they have shown subcortical white matter hyperintensities as compared to the adult patient population. And adult and children with bipolar disorder both have decreased frontal asymmetry. Regarding the pathophysiology, there are effects on different parts of brain, like for example, when viewing the angry faces relative to the control ones. So there is an initial message to amygdala, and as compared to this amygdala on ventrolateral prefrontal cortex, there is underactivity and possibly unable to modulate the excessive activity in amygdala. And it is interestingly correlates with clinical findings that bipolar children are overly sensitive to negative emotions, and that's why so this is given the name to the fountain of emotional reactivity. Children with the bipolar disorder showed the underactivity in face response circuit, visual cortex, superior temporal sulcus, and fusiform gyrus in response to both positive and negative phases. And it again correlates with the clinical finding that bipolar children have poor ability to decode others' facial expressions. In ventrolateral prefrontal cortex and striatum are overactive while exerting effort to stop or inhibit responses as compared to the healthy control ones. And it again correlates with the clinical findings that the children with bipolar disorder, they need to exert increased effort to inhibit these hyperactive impulses. While performing a cognitive task under an emotional challenge, bipolar children switched off their ventrolateral prefrontal cortex and dorsolateral prefrontal cortex, whereas the healthy children didn't. And concurrently, the amygdala was overreactive to negative words in matching tasks, and it clinically correlates with the high level of rejection sensitivity and extreme sensitivity to criticism, and that's the reason due to which the therapies, behavioral therapies which have a negative consequence, those are indicated in this patient population. On PET scan, ADHD children had reduced global cerebral metabolism and regional hypometabolism of premotor and somatosensory areas, and bipolar children had hypofrontality, and the diffusion tensor white matter imaging revealed prefrontal abnormalities in bipolar disorder and extensive abnormalities in 7 lower tracts in ADHD patient population. So these are the comparisons of MRI findings in ADHD and bipolar disorder patient population. So in dorsolateral prefrontal cortex, the volumes are decreased in both bipolar and ADHD, and anterior cingulate cortex, there is a decreased activation and volume as compared to bipolar disorder patients. There is only decreased volume, and in caudate there is a decreased volume, and in bipolar population there is either no effect or the volume is increased, and in putamen there is either no change in volume or decreased, and but here it's opposite, it's either no change in volume or it's increased in bipolar patients. So now we'd like to talk about dysregulation of systems in depressed patient as compared to the manic patients. In depressed patient there is a hopelessness and emptiness, while in manic patients there is a euphoria and irritability. And in depressed patients there can be increased sleep and appetite, especially in the atypical depression, and there is a decreased energy and sex drive, but as compared to these depressed patient, in manic patient there is a decreased sleep and appetite, increased energy and sex drive. So usually the manic patients, I mean, they just they can sleep 2 to 3 hours and then they feel fresh. So this is very typical finding in these manic, hypomanic patients. So regarding thinking, in depressed patients there is a internal concentration and slow thoughts, poor recent memory, and they have difficulty in making decisions, while the manic, hypomanic patients, I mean, they have external concentration, they have pretty much distractibility to the outside stimuli, and they have rapid thoughts, they are pretty much disorganized regarding the memory, and they make the decisions very quickly, and most of the times they can be wrong. So if I talk about the symptoms in depression, so and other mood disorders, the symptoms can cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. And there is another criteria of exclusion, that the symptoms are not the direct physiological effects of a substance or a general medical condition. And these are the DSM-4 criteria for diagnosing major depressive episode. So there should be 5 or more of the following symptoms which are present during the same 2-week period and represent a change from previous functioning. And these are depressed mood most of the day, nearly every day, while in children there can be irritability as compared to the depressed mood. And in my short experience, I mean, I have heard from the children, they never said that I am depressed. They use very kind of vague terms like I'm feeling bored, or they are kind of very much irritable, but they don't seem depressed as compared to the adult population. And there is a markedly diminished interest or pleasure in all or almost all activities most of the day, nearly every day. And this is very important finding, this anhedonia and also the suicidal thoughts. So these are the main symptoms in depression, which we should always pay attention while diagnosing with the major depressive episode. And there is a significant weight loss when not dieting, or weight gain, or decrease or increase in appetite nearly every day. And in children it can be failure to make expected weight gain as compared to the adult population. And there may be insomnia or hypersomnia in atypical depressions nearly every day, and psychomotor agitation and retardation, fatigue or loss of energy every day. Those can be the symptoms. Feelings of worthlessness or excessive or inappropriate guilty or inappropriate guilt nearly every day, and diminished ability to think or concentrate, or indecisiveness nearly every day. Recurrent thoughts of death, as I had mentioned before, not just fear of dying, and either having recurrent suicidal ideations without a specific plan, or a suicidal attempt or specific plan for committing suicide. So these are very important symptoms. The symptoms are not better accounted for by bereavement while diagnosing the patient with depression. And if I talk about a manic episode, so there should be a distinct period of abnormally elevated, expensive, or irritable mood lasting at least 1 week, or it can of any duration if the hospitalization is necessary. And 3 or more of the following symptoms have persisted and have been present to a significant degree, and those are decreased need for sleep, inflated self-esteem or grandiosity, more talkative than usual, or pressure to keep talking, flight of ideas or subjective experience that thoughts are racing, distractibility, increase in goal-directed activity or psychomotor agitation, excessive involvement in pleasurable activities that have a high potential for painful results. And there can be the mixed episode, and we call it mixed once the criteria are met for both a manic episode and a major depressive episode nearly every day during at least a 1 week period. And regarding the hypomanic episode, there are main differences once we label it whether a hypomanic or manic. One is a psychosis, which can be present in manic, but never in a hypomanic episode. And other thing is the duration. In hypomania, the episode can last like 4 days or so, while in manic, if the patient doesn't go to the hospital, it can be at least 5 to 7 days. And in this hypomanic episode, there is we call it hypomanic episode when there is a distinct period of persistently elevated, expansive, irritable mood lasting throughout at least 4 days, and that is clearly different from the usual non-depressed mood. And during this period, 3 or more of the signs and symptoms of manic episode are present, which are the episode is associated with an unequivocal change in functioning. The disturbance in mood and the change in functioning are observable by others. The other people can observe that the person is talking very fast, or very much disorganized, or jumping from one task to the other task without finishing them. So that kind of presentation. The episode is not severe enough to cause marked impairment in social or occupational functioning, or to necessitate hospitalization, and there are no psychotic features in a hypomanic episode. And then we can label them as mild, moderate, severe, and in severe it would be either with psychotic features or without psychotic features. And then in chronic, it can be in partial remission or in full remission. Sometimes there is a confusion in giving this either partial remission or full remission. The main criteria is that if someone has some depressive symptoms but not meeting the criteria of major depressive disorder, so then we can give the partial remission. Or it can be after the major depressive episode in within 2 months, if someone has some depressive symptoms, then it can be labeled as partial remission. While in full remission, there shouldn't be any symptoms of depression within 2 months period. Then it is called in full remission. And it can be with catatonic features, melancholic features, atypical features, with postpartum onset, and it can be recurrent type, with or without inter-episode recovery, or with the seasonal pattern. And regarding the dysthymic disorder, if there's a depression for most of the day, for more than not at least 2 years, then we use the term dysthymic disorder. And in children and adolescents, mood can be irritable and duration must be at least 1 year as compared to 2 years in adult population. While depressed, 2 or more of the following are present, which are poor appetite or overeating, insomnia or hypersomnia, low energy or feeling fatigued, low self-esteem, poor concentration or difficulty making decisions, and having feelings of hopelessness. As I mentioned, so the duration is 2-year period, and 1 year in children. The person has never been without the symptoms for more than 2 months at a time. No major depressive episode during the first 2 years, and again it's 1 year in children. And there has never been any manic episode, mixed episode, or hypomanic episode, and criteria have never been met for cyclothymic disorder. And then there are different types of depressive disorder, NOS, when the depression symptoms don't meet the full criteria of major depressive disorder. So those are premenstrual dysphoric disorder, minor depressive disorder, and it is episodes of at least 2 weeks of depressive symptoms, but fewer than 5 items required for major depressive disorder. It can be recurrent, brief depressive disorder, episodes that those last for from 2 days to 2 weeks, at least once per month, and not premenstrual dysphoric disorder. And post psychotic depressive disorder of schizophrenia, and the situation in which the clinician has concluded that a depressive disorder is present but is unable to determine whether it's primary due to a medical disorder or it can be due to substance induced. And in bipolar 1 disorder, it requires at least 1 manic episode during the course of illness, and it can be diagnosed in face of a current manic, mixed, or depressed episode, and there are no codified differences for diagnosis of children or adolescents. And in bipolar 2 disorder, it requires at least 1 major depressive episode, requires no manic episode, at least 1 hypomanic episode as compared to manic episode, and again there are no criteria different for children and adolescents. Cyclothymic disorder. There should be at least 2 years, 1 year in children and adolescents with numerous periods of hypomanic symptoms and numerous periods with depression that don't meet criteria for major depression. During this period, not without symptoms for more than 2 months. And we use the term bipolar disorder, NOS, when there's a very rapid alteration over days between manic and depressive symptoms that meet threshold but not duration criteria. And in bipolar disorder, NOS, there is a recurrent hypomanic episode without intercurrent depressive episodes, and hypomanic episode with chronic depressive symptoms that are too infrequent to qualify for diagnosis of cyclothymic disorder. And there are some recommendations from International Society for Bipolar Disorder regarding diagnosing the pediatric patient population with bipolar disorder. Those are number 1, manic or hypomanic or mixed episode prior to age 18, and acute manic or hypomanic or mixed episode meets adult criteria. And third one is if only chronic irritable mood is present and not euphoria or grandiosity documented. And there is an episode episodic decreased need for sleep and other symptoms are required for the diagnosis of an acute manic, hypomanic, or a mixed episode. And regarding the severe mood dysregulation, there is a criteria of onset before age 12, and there should be chronic irritability, hyperarousal, and longitudinal follow-up suggests increased risk for depression with ORSO is 7.2, not bipolar, and familial and MRI studies suggest different underlying pathophysiology for this. And while interviewing the patient, there can be some clues from the parent that the things were always going bad, and then suddenly the child started acting differently, or there can be a clues that patient thinking very slowly, there is elated, amusing, as opposed to the annoying behavior. These kind of clues that can be. And there are some age trends in bipolar disorder presentation. The younger the child, the more mood lability and irritability, ADHD, anxiety disorder, and separation anxiety, and there are hallucinations. And if the child is older, so then there can be melancholic or severe depressive symptoms, suicidal behavior, grandiose ideation, goal-directed activity and productivity, delusions and conduct problems, panic disorder, and substance abuse. Those are more in older children as compared to younger ones. So there are some differences between bipolar and ADHD in this slide. In bipolar, there can be psychosis, but in ADHD, no psychosis. 21% manic children, they are hospitalized, but the ADHD kids, they are not hospitalized. The sleep problem is episodic in bipolar, but in ADHD, it's more kind of chronic problem. And these are the 5 criteria which don't ever overlap. Those are elation, grandiosity, racing thoughts, flight of ideas, decreased need for sleep, and hypersexuality. These are the characteristic findings of ADHD as compared to bipolar disorder. And regarding the progression of illness in bipolar offspring, 10 ADHD plus family history subjects, those were assessed for 1 year, and there was 10% patient population lead to bipolar disorder. And here in 14 ADHD plus family history subjects, they were assessed for 3 years, and there was 36%. And regarding the treatment, there are different strategies which can be lifestyle, therapy, and medications. And regarding the lifestyle, there can be modification in the sleep, exercise, and avoiding the substances. And there can be education regarding getting enough sunshine, nutritional recommendations. and encouragement for socialization. And regarding the depression, there can be different therapies which can be used in addition to the medications. Regarding the treatment, I have separate actually handouts if someone would be interested, so I will be more than happy to forward electronically even. And for the treatment of these children, I mean, the involvement of the family is also very important. There are some book references which can be used for the parents, and also there are some books for the children. So these are the books which can be helpful for the children. There are some internet resources which can be used. And for the children, I mean, the involvement of the school teachers, that can be pretty much helpful. And this is the molecular and cellular neurobiology picture I have shown in this slide. Yeah, thank you very much. So any questions?